So hello, good morning friends. So we are going to start this session and I hope all of you will be able to finish your presentation in less than 2 minutes. So first is hidden villain anterior capsule flap stuck on endothelium masquerading as descemet detachment. Chief and presenting author Shweta Walia, she's here.
So good morning, friends. So this is a case of a patient who presented to us with the complaints of diminution of vision. He was a 55 years old and he came to us for second opinion since he was having blurring of vision since 1 year in right eye. He had history of right eye cataract surgery few days back, but there was no improvement in the vision. The vision in the right eye was 612 and there was a central corneal haze, and over here you can see something sticking on the endothelium, and on OCT we thought it was NTS detachment, but when took him on the table it was anterior capsular flap. So when this anterior capsular flap was removed and day post 7 the cornea is clear, corneal edema resolved, and we did YAC cap after 6 weeks. So the take-home message is always remove anterior capsular flap after capsular rhexis. It can go and stick anywhere, which can create unnecessary problems and complications. And post-operative counseling of the patient is very, very important. Take a pre-operative picture in cases of posterior subcapsular cataract. Polishing of posterior capsule is very, very important. And to avoid unnecessary medico-legal cases, this must be explained to the patient pre-operatively that he might need YAG capsulotomy at 4 to 6 weeks after the surgery. Thank you so much.
Thank you, excellent point. And you should always remove the capsule. And at times, when I have seen, not only it has post-op late problem, but even on the table, if the surgery is little prolonged, you are operating a hard cataract, things are not going well, then if the capsule is left inside, you may be confused whether it's a descemet or the capsule inside. So very good point, thank you. So we now invite the next speaker, Dr. Sunil Ganekal. I think, can we use both the podiums? Can we use both the podiums? Okay, so, hi. So I'll request Sunil Ganekal to come on one side. And the next speaker is Brijesh Thakkar. Is Sunil Ganekal and Brijesh Thakkar here? And after that, Devi Priya V. Yeah, come on. Devi Priya V. One on this side, one on this side. So we keep on calling on both the sides of the presentation so that we don't waste time. What's the name? Come on this stage, no, why you're waiting? So Sunil Ganekal is your name? No. The first one is Brijesh Thakkar is your name? So please come. So Sunil Ganekal is not here as of now. When he comes, we'll see. And after the Brijesh Thakkar, Devi Priya will.
So, good morning all, I am Brijesh. So, I am discussing a case which has caused me lots of anxiety over the last 2 years. So, this is a 51-year-old gentleman, he is from Maharashtra. He comes to us with a history of being a pre-diabetic for a long time, for 4 or 5 years. And under my care also his HbA1c has been maximal around 6.2% with fasting glucose levels hovering around 115 milligram per deciliter. So I've checked this again and again over the last 2-3 years. His left eye had macular edema which was significant, and he had been treated prior to coming to me, and we also treated twice with both steroid implants as well as anti-VEGF injections as well as a session of focal laser. It was kind of controlled. So he's okay. Left eye vision is slightly low, but he's okay. Unfortunately, his right eye started progressing. So if you see the dates which are mentioned, 30th of January last year and then 23rd of January this year, we find that slowly macular edema is happening again to the other eye also and encroaching the center, even though the vision remains same. CMT was 310 in the bottommost panel, if you see my cursor, and this is the cystoid space coming up. So the question over here is, how should I stop or how should I prevent the right eye from having the same fate as the left eye has had? So I went on through the literature, and if you can make out these graphs, this graph over here is from a systematic review which was looking at the prevalence of diabetic retinopathy in pre-diabetic individuals who have never had diabetes. And it seems that the median prevalence is around 7%, whereas for our region, which is Southeast Asia or India, the prevalence is much higher, 18%, 19%, something of that sort. And the forest plot over here shows the individuals who can develop central macular issues even in presence of pre-diabetes and not in presence of diabetes. So the question over here is, I send this patient to the endocrinologist who says that I will not give OHS because the patient may just collapse, he has normal sugar levels. I have no way to stop the right eye from progressing, and we look at if we have some alternate ways which can stop DR from progressing even in pre-diabetic stages. And definitely there is something other than hyperglycemia which has a role in this.
Thank you, Dr.
Thank you.
Brijesh. What do you think is the cause? I mean, is it really diabetic? Because we know that these type of diseases can have a different expression. That means some of the diabetics may have kidney problem, others may have eye problem. So is it because the basic pathology is hypoxia? Is it something else causing hypoxia, or it is the expression of the diabetes itself? What is your opinion?
So over the last 2 years, Dr. Lal, I've gone through all kind of tests, whether it is inflammatory disorders, connective tissue disorders, the general testing that we do. And he's with me for 2 years, so I have, gone through that passage as a doctor-patient relationship. So he is a hypertensive also, he is a dyslipidemic also. There is a metabolic syndrome which is happening over there. And I believe, I personally, I don't have any proof to such, any evidence to support this, but I think this is a metabolic memory which has developed in him over the years.
Do you think it has any correlation with the HB1AC level or any other indicator by which we could predict
Yes,
that,
doctor. So
which
last
people
year when we treated him, his HbA1c, sometime, it came to 5.8, 5.9.
That is
after
quite
using Diabexi, ATA, and certain neuroprotective agents, which I, got him to use after in conjunction with a neurologist. And at that time, his left eye, the CMT came down by itself. So obviously that relationship is there, but in conventional ways, how do I prevent the right eye from worsening? I can't give OHs.
So I think a long time back when I was postgraduate, and at that time Michelson and Ballantyne book of retina was very popular. So they said, they described the retinopathy because of hypoxia, which may be, the causes may be in the wall, like hypertension, in the blood, like in the serum, like diabetes, or sickle cell anemia, or in both, in many. So they enlisted around 15 causes or so. So the basic is that the hypoxia is the main culprit for development of this edema, and whether it is actually diabetic expression or something else is happening which we are not investigated as of yet. So anyway, thank you for bringing up a wonderful point.
Thank you.
So now I'll call upon Dr. Devi Priya to go ahead.
Eyes, windows to the body or soul? There is audio in it. Can you please play?
Eyes, windows to the body or soul? Come, let's find out. 47-year-old lady came with a complaint of defective vision, right eye 10 days duration. BCVA right eye 612, left eye 66. Both eye anterior segment was normal. Both eye fundus showed angiosperm streaks with right eye subretinal hemorrhage suggestive of CNDM. OCT showed SREM and OCTA, and the right eye showed a vascular network. This is the FFA of the right eye, revealing hyperfluorescence increasing in size and intensity over time. After 3 intravitreal injections of ranibizumab, You can see the reduction in subretinal hemorrhage, reduction in strength, and vascular network. She was then referred to a physician who diagnosed her to have pseudoxanthoma elasticum. Indeed, eyes are windows to the body. Thank you.
How was the diagnosis made of like what, how did you investigate him?
I didn't investigate. I referred to a physician. Actually, skin biopsy was actually done to confirm
Do you
pseudoxanthoma
have any
elasticum.
skin lesions as well along with the angioid stream?
There were non-specific lesions on the neck, and I didn't examine more than that. So I referred to a dermatologist and a rheumatologist to rule out everything else. Then skin biopsy was there to confirm pseudoxanthoma elasticum.
Okay, so did it have any bearing with the treatment of the eye as well? Like, was he
Usually
started on any treatment specific, and did the eyes respond well after the treatment?
No, actually they're prone for premature atherosclerosis. The patient was started on statins and other aspirin like that, but that did not influence the treatment of CNVM in the eye.
Dr. Anurag Kumar Kashyap
thank
is the
you.
next.
Thank you.
And Jasneet Kaur after that. So keep on looking at your name and please keep on coming to the next podium. Dr. Anurag Kumar Kashyap, Dr. Jasneet, Dr. Jeba Khanum. Yeah, Dr. Jasneet,
Yes, sir.
go ahead.
Choroidal osteoma, a diagnostic dilemma. 55-year-old female on routine fundus examination was found to have a well-demarcated mass lesion only in the right eye. The round yellowish lesion in the juxtapapillary area had slight hyperpigmentation over the temporal margin, and the size was roughly 4.2 into 4.3 mm. An OCT scan done through the lesion revealed a homogeneous isoreflective localized elevation with intact photoreceptor layer, and there was absence of any retinal edema. The B-scan ultrasonography showed posterior acoustic shadowing with a double optic nerve sign suggesting ossification, which is characteristic of this lesion. The rest of the fundus in the right eye was within normal limits, and the left eye was also normal as well. So a few differential diagnoses needed to be ruled out. Thank you.
Any point you want to make with this? Like, I mean, what's your take-home point with this case? Like, obviously we'll do an ultrasound to see whether it's any tumor or anything. I mean, did you further investigate or anything else that we need to consider while evaluating such cases?
Ma'am, first of all, the patient was a known case of CA. So any elevated hypopigmented well-defined lesion at the posterior pole, it needs to be evaluated to rule out METs first of all. And since the patient was in remission for the past few years, so we just want to spread awareness regarding this rare entity.
Thank you.
Now, next speaker is Dr. Jeba
Zeba Khanum.
and after that, Dr. Arnab Mandal. Is he here, Dr. Arnab Mandal? So please come on the other side.
So myself, Dr. Zeba. So my video is on the double
CTR Savior in 5 clock hour zonular dialysis.
9 to 2 clock hour zonular dialysis.
Bag stabilized intraoperatively using 2 CTR placed diametrically opposite. Slow phacoemulsification done with gentle cortical aspiration and minimal anterior fluctuation to maintain the shape of capsular bag and to prevent vitreous prolapse in anterior chamber. Three-piece IOL inserted in the bag and small capsulorhexis is enlarged to prevent anterior capsular fibrosis with microcapsulorhexis scissor and Utrata forceps. Intracameral triamcinolone injected. No vitreous tag noted and IOL stable.
I really don't know whether the double links actually help, but most of the time if there is a gross jonular dialysis, it is better to use capsular hooks, which will stabilize initially, because at times if the jonules are weak, and once you put two rings, probably may be very difficult to pull out the cortical fibers. But anyway, until unless the eye is very large, high myope, where you feel the ring will be small, or if the ring is not of good quality, but if the end of the rings actually are overlapping, I don't think putting two rings are going to help.
So, but in this case, after the post-op surgery also AC was maintained, there is no fluctuation, as well as in when we put a CTS, the Ionis, then there is a chance of scleral fixation is also done. But in this, it's an easy procedure to put while surgery also in the left side.
Okay, thank you.
Thank you, sir.
So we have the next speaker, Arnab Mandal, and I'll request Divya Kesharwani to be on the other side. If Divya is not here, then Dipankar Deep Shekhar Das.
Good morning. I'm Dr. Arnab. My topic is proper plane of dissection to prevent flap necrosis in master disc rotation flap surgery.
Presented with slowly growing painless lower eyelid mass since 2 years. No signs of local or distant metastasis was. MAP biopsy and incisional biopsy confirmed sebaceous gland carcinoma without pagidite spread. Later, the entire mass was excised with 5 mm clear margin. Then when the flap was preparing, I did a mistake by going superficial to the deep subcutaneous plane. Hemostasis was secured and flap was advanced and sutured. Then post-oral skin incision was done and conchal cartilage graft was prepared and placed as a posterior lamella of the eyelid, and it was sutured. And this was immediate post-op, and on follow-up period there was scrap necrosis at the sutured area, then debridement done and secondary suturing also done. This is third month. Flap dissection at deep subcut level is important to prevent flap necrosis. Thank you.
Thank you. Nicely done.
Thank you.
Next, should I start?
Divya Kesarwani is here. Dr. Divya. Deep Shekhar Das.
That's nice. Good morning, everyone. Good morning to the respected judges. So my topic is phacoemulsification incision simplified. So in the modern era, as we all know that I don't have any financial disclosures. So in the modern era, phacoemulsification is the most common cataract surgery that is routinely performed. However, in the present scenario, even still till date, residents and amateur surgeons have doubts regarding how to tackle astigmatism and surgical wound construction for phacoemulsification. So herein, in a video, I have demonstrated roughly 4 basic principles which a surgeon can follow. So the first principle is cornea flattens in the axis where the surgical entry is made. Second is superior incisions lead to more flattening, followed by nasal, then temporal, leading to the least flattening. So here example is that when you make a superior incision, there is astigmatism correction of roughly 1 diopter. For nasal, it's roughly 0.5, and for temporal, like 0.25. It depends upon various other factors as well. I'll go into it. So the implication is that superior incisions are recommended for with the rule astigmatism. That is vertical axis whenever it's steeper. And for nasal, it can be tried when it's against the rule astigmatism. Another thing is that the larger the wound, larger is the astigmatism. However, 1 to 3 millimeters of entry, they don't have any significant astigmatism. And the last one is that the incision, whenever it's more closer to the center of the cornea, that leads to more astigmatism. So in conclusion, mastery of this incision technique requires a fine balance of technique, control, and anatomical understanding, which comes with practice and mentorship. These are my references. Thank you.
So I think, so far as the incisions are concerned, the first and foremost is, of course, having the comfort of the surgery.
Yes, sir.
That means if you feel temporal incision you are comfortable with, you should go ahead with that without worrying about if you feel the eye is deep set and you are not very comfortable operating from superior or nasal side.
Yes.
Secondly, I think I had a thesis topic on LRI and opposite clear corneal incision.
Yes, sir.
So this now with the modern toric IOL,
Yeah.
so they give excellent results. So this
So this
factor of flattening by the incision is best reserved for 0.5, 0.67 below that. And specifically, if you are using the EDOP or multifocal lenses, this small amount of astigmatism also gives
Pseudo
depth,
accommodation.
good.
Good pseudo
Yeah. So if there is, you are using the EDOP lenses, then EDOP lenses are providing good depth over there. So you don't actually, and they, because EDOP lenses reduce the contrast and astigmatism also reduces the contrast, you don't want two factors reducing the contrast. So in those cases, this technique will be very, very helpful when it is less than 0.7, 0.5, and you give a steep incision. If it comes down, you don't have to worry about whether it's a nasal superior temporal. Just mark the exact axis, whatever you are getting on a keratometry or IOL master. And in any case, if you practice this, slowly and slowly you will start understanding astigmatism better. But if you don't want astigmatism, I always prefer to give an incision slightly on the limbal side where slightly it oozes. That hardly causes any astigmatism, because only thing, if you go further posterior, there is chances of conjunctival chemosis. Incision as peripheral as possible without causing a conjunctival chemosis is the idea. Thank you. So we...
Thank you, sir.
Yeah. We invite the next person.
Dr. Sumedha Vats. Yeah, please start.
And meanwhile, the next person should be ready. Dr.
Dr.
Vipul Arora on this side.
Good morning, everyone. Today I'll be talking about how we approached a case of granulomatous uveitis. We had a 47-year-old male who presented to us with sudden onset diminution of vision, floaters, redness and photophobia in the left eye of 7 days history. On examination, the right eye was thiacical. He had lost it to trauma 20 years back. The vision was PL negative. In the left eye, the vision was 618, a pressure of 48 millimeters of mercury. The anterior segment evaluation revealed granulomatous KPs, a flare and a cell of grade 1+. On the fundus examination, the media was grade 1, there was vitritis, a macular scar was seen, and a patch of retinitis in the infero-nasal quadrant was seen. So the point I want to make here is we got a patient with a history of trauma to the other eye and granulomatous uveitis in the seeing eye. We thought of sympathetic ophthalmia. The other possibilities that could be there were tuberculosis and sarcoidosis. However, I want to emphasize that a high index of suspicion for acute retinal necrosis in a case of granulomatous uveitis with raised IOP should be kept, and a thorough peripheral fundus examination is always worthwhile. Thank you.
What treatment was done?
The patient was started on IV antiviral, sir, acyclovir, 10 mg per kg body weight, 3 times a day for 14 days, and thereafter put on oral antivirals, sir.
And how the glaucoma was managed?
The glaucoma was, he was started initially on tablet Diamox 3 times a day, 250 mg, along with the topical anti-glaucoma, that is Simbrinza, the brimonidine plus brinzolamide and timolol.
So during the treatment, how was his IOP was maintained?
So
it was
on starting the anti-glaucoma, sir, it was managed by the same evening the IOP was under control, sir.
So because I really don't know, because you are not mentioned over here, if patient is one-eyed and upon the maximum medication, if the IOP is not controlled, I think we should not hesitate and go and do definitive procedure, what is required to bring down the pressure. Because already there is so much of a compromised eye, so we need to bring the pressure down immediately. And most of the time, initially, if the pressure is high, local medications don't work so well. So you give the mannitol or bring the pressure down, or do the paracentesis on the slit lamp and bring the pressure down, and then the medication starts working better.
So the patient responded instantly in an hour to the or two to the medication. So then we didn't think of mannitol then. That's
Okay,
right.
thank you.
Right.
Thank you.
So good morning, respected seniors and dear friends. Today I'll talk on primary posterior capsular plaque peeling. So central posterior capsular plaques are not uncommon to find, and occasionally they may be thick enough to affect the visual outcome in immediate post-operative period. Of course, it's always acceptable to yak them later. The tips of doing successful plaque peeling is to increase the magnification and focus that the posterior capsule is not held. Do not overfill the chamber with viscoelastic and to find the cleavage plane and hold the edge of the plaque with the capsular access forceps. Flap should be held firmly and should be recrest again if the need be. And this may lead to a successful capsular plaque peeling. Thank you.
Thank you, very good point. I think all these blocks can be easily removed, and most of the time I will use 26 gauge needle to lift initially and to create a plane and then try to pull it out. But if any stage of time you feel there is a jonular weakness or high myopes where you feel that the jonules are under pressure, because definitely there is no danger of having PCR over here because there is a definite plane is there, but the jonular damage can take place. So if you feel that the jonules are weak and you are putting too much of a pressure, it's better to leave it there. Thank you.
Thank
Very
you,
good
sir.
point. So we have the next presenter.
Dr. Divya Kesarwani.
Dr. Manu Sharma.
Dr. Manu Sharma.
Good morning, everyone. Thank you for this opportunity. So my video is self-explanatory. It's a trick for removing anterior chamber oil. When you are fiddling with the aspiration or AC washing, it's always a disastrous thing. So we can remove the oil easily, the oil bubbles, with the infusion, this silicone oil removal cannula. Passively, it's coming very easily. In the meantime, you can gossip around. It's freely, passively, by the capillary action, it is being removed. So you don't have to do anything. Just place the silicone oil removal cannula inside the AC and the oil bubbles will passively come out. Thank you.
Thank you.
Thank you.
So, any other question?
Any questions?
So if the oil keeps on coming, what do you do?
It will be passively removed. Before removing the oil from the AC, we have already removed oil from the posterior chamber. So these are the retained oil globules which are coming out.
So many times while we are operating as an anterior segment surgeon, and the oil has yet not been removed.
No. For that, it's not. We have to remove oil first from the posterior segment. When it's completely removed, it is the residual.
There may be patients
Yes, sir,
where the oil removal is not yet indicated,
Yes.
but the patients have developed a cataract.
Yes, sir.
So now you can see some of the silicone.
Yes, sir. The residual emulsified oil that can be removed passively by this technique.
So in any case, I think the trick over will be that maintaining little higher pressure into the anterior chamber,
yes,
so that the oil, because the oil being the lighter than the water tries to come into the anterior chamber, put on a viscose type of a material, press the iris against the capsule,
Yes, sir.
and do not let the, vacuum pressure should be low, so there is no chamber fluctuation, and not lowering of the IUP. Probably you can prevent to some extent the oil sometimes keeps on coming while you are
It's
operating.
passively coming out. We don't have to do anything actually.
Okay, thank you. Now we go on to the next Dr. Mayur Patil.
Dr.
Dr. Divya.
Okay.
Dr. Divya Kesarwani.
Okay.
Good morning.
And on the other side, I'll request Dr. Mayur Patil to be on the other side.
So good morning everyone. So I will be discussing about a case who is operated on a combined cataract and glaucoma surgery. So this patient, after post-op day 7, this patient had high IOP and everything in spite of bleb was flat, other things were normal. So tight sutures were suspected, and with even after bleb massage and on 2 medications, the pressures were not getting controlled. So there was corkscrew vessels also present, so we gave the patient fluorouracil injections. It was repeated twice, and then again there were signs of early failure of the bleb. So we had to take this patient for bleb revision, needling, and we had to remove the tight sutures with the needle, because at certain settings where laser suture lysis lens and the other facilities are not available, and sometimes even sutures are not seen. If we want to do the laser suture lysis and 2 weeks have been passed and there is an evidence of early scarring of the bleb, then we had to remove it manually by ab external approach. So that we did.
Your
videos.
This is your presentation.
This one is mine.
Just a minute. Just a minute.
This is hers.
So So I would like to emphasize on the take-home message that removal of the tight sutures that improves the IOP control by allowing the better aqueous outflow. And this bleb revision is done usually in the settings where the suture lysis lenses are not available, or sometimes the sutures are not seen. So that's a good method, and it's a minimally invasive approach to do the removal of the tight sutures.
So after how many days, a month, you feel that bleb revision will work? And secondly, the music was unnecessary over here. We could not hear you better. So if you are keeping the music, keep it low or don't keep it. I mean, such a short presentation, it was just disturbing more than actually adding to the presentation.
Yes, it was really very fast.
So after how many months and what is your time frame?
Bleb revision is the last resort. So ideally, if we suspect that the sutures are tight in the initial 1 week post-op time, so ideally it is the releasable sutures which should be given. But in conditions where if you are not giving the releasable sutures and on day 7 you find that it's because of tight sutures, then you have to make a balance between whether you have to take care of the wound healing as well as you have to prevent the hypotony also. So taking care of that balance and giving bleb massage on medications, everything we have, this patient had early scarring. So that is why we had to revise the bleb externally and we had to remove the sutures within.
This was how many months old?
This was 3 weeks.
3 weeks only?
3 weeks only.
So
that was an early phase. That was not an ideal time for bleb revision actually.
So I think the bleb revision will work if you do it early on. But if the scarring is really formed up,
yes,
I doubt whether it is really going to work.
Yes.
And so far as the hypotony is concerned, I have not found the hypotony actually taking place even after 1 week. But a reasonable amount of sticking of the flap and fibrosis has taken place.
Yes.
So I think if the IOP is on the higher side,
yes, it was
24, 25,
45
after the
like
trabeculectomy, we like to keep the IOP around 10, 12, so that after fibrosis it can go a little up. So if, normally if it is beyond 25, we should not hesitate, though it can be controlled by the medication. But I rather prefer to release the suture if the IOP is beyond 25.
Yes, on day 7 it was around 48 or something. The baseline was around 23. And then after day 3, post-op pressures were absolutely fine. But then on day 7 it started rising. So we had to intervene considering the failure of the bleb.
Okay, thank you very much. And absolutely there should be no hesitation in removing at least releasing the sutures. You don't have,
yes.
I mean, you don't have to even make such a big flap. I usually take a needle, pull the conjunctiva
Yes.
on the one side and just go with the 26 gauge needle and go between the flap and cut the suture and leave it over there.
Yes, sir.
So very simple technique which you can do very comfortably without any.
This can be done in every setting, so that's a good thing. Thank you.
Okay, so we now go to the next presenter, Dr. Mayur Patil.
Good morning, all my respected teachers and my colleagues.
To this lenticle insertion. First, let us review the conventional method of lenticle insertion. Using a glide, the lenticle is introduced into the anterior chamber with the help of Sinski's hook. As you can observe, the anterior chamber shallows during this process, making the removal of hook challenging. This results in crumpling of the lenticle, which may increase the risk of endothelial damage. To address these challenges, I propose alternative technique using a bent 26 gauge needle attached to a 2 cc syringe filled with balanced salt solution, eliminating the need for a glide. After applying the liberal amount of viscose near the tunnel with the needle, the lenticle is inserted. As the anterior chamber shallows, BSS is gently injected to deepen the chamber and also to facilitate the centering of the lenticle. As demonstrated, this technique allows for smoother insertion and easier centration, significantly reducing the lenticle manipulation and minimizing the risk of endothelial damage. The take-home message is that with this simple modification, DSEC insertion can be made easier, safer, ensuring the better post-operative outcomes. Thank you.
Yeah, so it is a better way. Even I do the same way. But what do you use before inserting the lenticule?
Before,
so you have to put Helon GV on the
yes, sir.
conjunct.
Yes, ma'am. Yes,
so you didn't mention that.
I mentioned that.
And while you are taking out, you have to be, you have to gently tilt your needle laterally and then slowly take out, so that
yes,
otherwise the graft will also get pulled back.
Right,
so
right,
and after inserting, you just put a very small air bubble initially, and then you adjust the graft, and after that you can inject a larger air bubble. So all these, they help in centration, and this works very well. Yes, thank you.
Yes,
yeah.
Dr. Iva Rani Kalita.
Kalita.
Is she here? Next is Dr. K. Sairani. And after that, Siddharth Ghosh.
An uninvited guest masquerading as an eyelid swelling. A 51-year-old woman, housewife coming from rural area, presented with painful swelling in
Can you keep the volume a little low because we are not able to hear the
progressively
speaker?
increasing in size over 3 days. On slit lamp examination, like appendages were seen moving over the lesion. With the 24 gauge sterile needle and cotton bud, the insect was removed intact. And the insect was identified as female soft tick, which was enlarged over 3 days after sucking the blood. After removal, you can see the local erythema at the site. And it was treated with local topical steroid and antibiotic treatment. You can see the insect tick was crawling. And it is an ectoparasite living over the takeover messages. It's crucial to remove the tick in toto, and any remnants can produce inflammatory or infectious lesions. If it occurs, you can thorough general and serological tests to be done, and also you can give oral antibacterial drugs if needed. The ticks are ectoparasites, presents lives over the hematophagy of mammals, reptiles, and birds, and the vectors for many tick-borne diseases like scrub typhus, Q fever, tularemia, Lyme disease.
So it's most important to remove it in totality,
Yes.
not to leave any remnant. Thank you, ma'am.
Dr. Siddharth Ghosh. Okay. And meanwhile, Dr. Urvaja Chaudhary, if she's here. Ajo.
Good morning, everybody. So this is a video on successful management of, will you please play? Successful management of an incomplete femto laser cap cut during the silk surgery. So as we see that when we started the surgery, the patient is well centered and applanation could be well achieved. Even the laser was fired well, but at this point of time, it's not a real-time image and we could not see that the patient had slightly shifted. And when we took him on the microscope, we could not find the entry cut at all. But as we see, the other parts of the laser are well centered, the OBL is well formed, and therefore we tried to give a manual entry cut with the help of a side port knife. So a manual entry cut was made with a 15-degree side port, and since there will be only one plane, there was no point of getting any wrong entry or anything. And we could easily find the anterior as well as the posterior planes with the help of the dissector. After understanding that both the planes are nicely formed, then we entered the entry, the anterior and the posterior areas, and the lenticule could be dissected out very smoothly. And had a very good post-operative visual outcome as well. So in case we have a disturbed femto entry, even then the lenticule procedure can be carried out.
Yeah, so in fact it's a very common
Yes.
thing which happens during SMILE as well. And we have to be, if after
Very
certain
careful.
practice, yes, we get the hang of it, that where we have to put, and if make sure that both the lenticles are properly dissected
made.
before you go in and do these
Ma'am, but
maneuvers,
here
yeah.
one more challenge was that with silk, we don't have the visual while the laser is being fired. So we don't exactly know at what point the patient had moved. So we have to like assess according to the OBL formation. I had one more patient, same patient. In that, the patient had moved slightly 2 seconds before the entry cut. So even the anterior plane formation was decentered. So there we did not try this.
Yeah, so it's
there
a very,
we turn how
very
we converted
strategic
to
balance.
flap
We have to see whether we have to continue the surgery or best is to just abandon it
and
or
convert it to
into
flap.
Yeah.
Correct.
Thank you.
Thank you.
Nice. Dr. Ghosh, please.
Yeah. Good morning, honorable judges and my seniors and my dear friends. I'm going to talk about, the tricks of pupil management in uveitic cataract. This is a very important step in managing uveitic cataracts. And very often, we really, if we mismanage this step, we are going to be inadequately treating and having problems here. So after putting adequate viscoelastics, I use a blunt spatula or a iris repositor to break the posterior synechia so that it should be done meticulously from all sides, not injuring the iris at this point of time. And then I want to emphasize that we need to peel off all the pupillary membranes that are there, not all at a time, one by one, slowly segment-wise, so that all the membranes are taken away. And then put more viscoelastics and stretch the pupil with 2 instruments so that we can accommodate a pupil expansion device. Here it is. We are implanting whatever device is available with us, we can use, so that we have adequate amount of pupillary exposure to deal with these cataracts. So once this pupil expansion device is in place, now we are all set to go ahead for the cataract surgery. Thank you.
So, in your case, everything is fine, but I don't agree with the initial peeling off of that because sometimes it just leads to bleeding and it just creates a mess. Instead of that, we can just use a hydrocannula or a vitreous sweep to just sweep the membrane and just get a plane for the rexes. And after that, you can use pupillary expansion devices, or you might need it. You might not even need those.
Yeah, you're right, madam. But sometimes, if we don't peel off the membranes, it will not stretch enough to accommodate the pupil expansion.
No, if you gently take your cannula just below the in the plane or between the capsule and the iris, they automatically get at least separated. Sir,
So I find most of the time the biggest challenge is how to stain these capsules. Yes. So if you put on a viscoelastic before, then staining of this capsule becomes little difficult. Then you have to remove the viscoelastic to stain it. So normally what I do is I use irrigation aspiration cannula. One side I put the infusion on, other side I take the suction port, which I'm not using as a suction, but going between the iris and the capsule to separate the synechias. And then stain the capsule because it gives good enough dilatation at that stage. And after staining the capsule, then you put on a viscoelastic. At this stage, if your dilatation is good, and if there is a very thick fibrous band which is not allowing it to dilate, you can peel it off, keeping in mind that there is no iododialysis over there. Don't apply too much of a force. But if it peels off nicely, it's very good to peel off nicely, because then most of the time you don't need to put any rings or hook. It really gets widely dilated if you put on a good viscoelastic, and you can complete the surgery because the lens is very soft, comes out very easily. Exactly. So it's only if the cataract is hard, if the patient has come very late, then you must put on a Malugin ring or Bhattacharya ring over there, because the surgical time is prolonged, inflammation will keep on taking place in those cases. So thank you very much.
Thank you.
So very well point brought out.
Thank you, sir.
Now we will go to the next speaker, Najwa Serene.
Yes, sir.
Yeah.
A very warm good morning. I am Dr. Najwa Shirin from Madurai Medical College, Tamil Nadu. So this is a 23-year-old female with complaints of diplopia on leftward gaze. She has nystagmus in left eye and adduction restriction in right eye. And on rightward gaze, she has nystagmus in right eye and adduction restriction in left eye. This is a bilateral internuclear ophthalmoplegia with lesion at the level of bilateral medial longitudinal fasciculus. Her MRI showed Dawson's fingers and hyperintensities involving bilateral medial longitudinal fasciculus. This is a 62-year-old female with complaints of diplopia. On rightward gaze, she has nystagmus in right eye and adduction restriction in left eye. This is a left internuclear ophthalmoplegia with lesion at the level of left medial longitudinal fasciculus. Her MRI also showed hyperintensities in left medial longitudinal fasciculus. So internuclear ophthalmoplegia is a localizing sign, and in both these cases, it was the clue that led to multiple sclerosis diagnosis. Thank you.
Yeah, thanks a lot. Dr. Irfan Mohammad Khan is here. Dr. Ashutosh Kumar Gupta.
Dr. Kavita Ramakrishnan. And just I'll see that at number 2, Sunil Ganikal was not there at that time. Is he around? And at number 5, Anurag Kumar Kashyap was not there. If they have come, please come forward.
Very good morning and honorable judges. Gaucho's grip is a slang term used for skilled footballers from the South America. Strategies to tame a intermittent cataract are intralenticular needle decompression, minirexis, asterisk opening in the interchamber, femto, zepto, and capsule laser. I am presenting a very consistent strategy which I am finding very much promising, and that is a puncture axis. Have a look at case 1, 2, and 3. I am in phaco position 2, making a punch hole in the intercapsule and then completing the rexis by taking cuts with the Vanna scissor. The decompression is not only anterior but also posterior. Case number 2. Although you will find that there was an extension, but it is not such an alarming extension that it goes to the equator. So I am finding this to be a very consistent strategy from the last 50 cases, which I am employing in all cases of intermittent cataract.
So what are your parameters in this?
Sir, I am putting it at a default of whatever the settings of earthly machine is there.
How much? What is the
earthly machine parameters are 65% phaco power, 450 vacuum, and 45 aspiration flow rate.
So I'll give you a much simpler technique, and I've been practicing for now last more than 5 years. I do the same I was talking about. I use the IA cannula, put an irrigation from the one side and the aspiration port from the other side, and do the lenticular massage. That means you just press and do the compression of the anterior capsule. All the pockets will be broken. Cortical matter will get dissolved into the pockets over there. I never had any extension of the capsular axis, even if you make it 7 millimeter large axis. So all the lenticular pressure is gone. So very simple. Earlier on, I used to put on a viscoelastic. Then again, the problem was how to stain and dye it. Because if I put on a viscoelastic beforehand, then do the massage. If I dye it before, the dye just washes off while you are rubbing it. And if I put on a viscoelastic before, then it becomes difficult to dye. So now I use the IA. I put on irrigation to maintain the chamber and massage with the aspiration port, and you will never ever have run up of the axis. And this puncture axis was of course described by Mohan Rajan earlier, and it looks very scary actually when you try to do it. I mean,
but I have never encountered any kind of extension.
Yeah. So
and the advantage I am finding is that there is a possibility of a posterior decompression, which, as you express,
I'm not debating. It works very well in your hand, but didn't work so well in my hand.
Yes.
So what I'm saying that there are safer and comfortable methods are also available.
Yes. Thank you very much.
Oh, thank you. So now we invite Dr. Ashutosh Kumar Gupta.
Morning, sir. Morning, ma'am.
And next is Dr. Kavita Ramakrishnan to be on the other side. Yeah, please.
In next 1 minute, I'm going to present the strategies for management of large macular hole. The macular hole, as such, the size increases, the surgical success rate decreases. So there are three main strategies. Number one, temporal, use of temporal flap, which I have shown in the first case. This is another case. There is a, the macular hole size was roughly 1050, that is more than 1000 micron. Here I have used multi-layer ILM flap with a, there was a good success rate with closure of the, type 1 closure of the macular hole. The another technique is use of a massager, macular hole massager, that I will show in the third technique. Here I have modified, in the market there is titanium macular hole massager, but here I have used the soft tip, which is easily available in the OT. So these are the three techniques which are helpful in getting a higher success rate in cases of large macular hole.
Any specific point you want the audience to take from this?
Yeah, ma'am. According to the closed group study published in 2023, the success rate of small, medium, and large macular holes, large macular hole of size less than 535 micron, the success rate is 96%. As the size of the macular hole increases, means if the macular hole size goes to 800, the success rate decreases to around 90%, and if it's more than 900 micron, the success rate goes to 75 to 80%. So with the help of these techniques, we can get a better success rate as compared to conventional technique of PPV and ILM peeling.
Thank you.
So is it the visual improvement, or it is the fear of that the fluid may seep from there?
No, sir. It's both. It's both, sir.
Okay, thank you.
Thank you, sir.
And the next speaker on this side, please.
Dr. Mridula Gangavar.
The eyeball is a rare condition.
Dr. Mridula is here.
The equator of the globe protrudes anterior to the eyelid aperture. It is an emergency and can occur following major or trivial injuries. It carries a risk of permanent visual loss due to associated optic nerve injuries. A 2-year-old child presented with injury to right eye with bike handle. Globe was luxated with lag of thalamus and dilated fixed pupil with restricted eye movements. Ultrasound revealed stretched optic nerve. CT imaging showed deviation in the course of the optic nerve with air pockets. Under general anesthesia, the upper eyelid was lifted and pulled over the globe with DMA's lid retracted, simultaneously pushing the globe posteriorly into the orbit to reposit the eyeball. Lateral temporary tarsorrhaphy done with 6-0 silk suture to restrain the reposited globe. Prompt recognition and reposition of luxated globe is essential for anatomic restoration and aesthesis. In some cases, recovery of vision is possible if immediate action is taken. Thank you.
So what was the vision like in this case, ma'am?
Yeah, this case, unfortunately, the child had a CR wave.
Along with it, yeah, it was looking like a cherry red spot.
Yeah, so this child didn't recover vision. We have a collection of 4 cases. So one girl recovered vision completely, 6/6 vision. There's another which was a very bad luxated globe, which required multidisciplinary approach. So the main thing is, it is not rare. It is given in the literature as luxation is rare, but it is not so rare, and even trivial injury. So in most of our cases, it was because of a bike handle injury. So, and it is important for general ophthalmologists to know this condition and recognize and refer immediately to oculoplastic surgeon.
Absolutely, ma'am.
So I think recognition is not a problem for any ophthalmologist. Only thing they don't know what to do. Another, what I was thinking, there was when you're trying to close the sutures, there was a lot of pressure still inside. Do you think any decompression like we do in...
yeah, I have not shown because it's short video.
Either the floor or the medial wall or the lower wall fracturing, so that there is not some of the loss of the vision, maybe because now you really put the eyeball under a lot of pressure over there. So I was just wondering whether it would be worthwhile trying to do some decompression.
No, so for this case, actually we let out some retrobulbar blood, so that was let out. This was a very short video, so I couldn't show that. So we let out the blood, and most of these cases, the bolsters is retained for maybe a week or so. So after that, the eyeball settles down. So it's most important to reposit.
So does it become cosmetically same as the other eye eventually?
One case went in for thiazical eye. One went in for phthisis.
Okay, thank you. Now we come to the next presenter.
Good morning, everyone. Please play my video.
Kya naam hai?
Dr. Mridula, sir.
Doctor.
Dr. Mridula Gangwar.
Okay, okay.
As you saw, sciatic macular detachment was there with multiple Increase the inferior volume, breaks please. and retinal detachment. So, encerclage was done and adjusted well. First, silicone oil was removed. As you can see, there are multiple holes with secondary membranes which were removed with forceps. These secondary membranes were very adherent and difficult to remove even with forceps. All the bleeding sources were endodiathermized. You can see the detached macula while removing the membranes. So BFCL was injected followed by fluid air exchange. Subretinal fluid was aspirated thoroughly through these breaks. Endolaser was done around these breaks as well as the buccal indent. For tamponading, silicone oil was injected and eye was closed. Thoroughly removing all membranes and tamponade is the key to manage such complicated cases.
Yeah, so diabetic RDs are typically nightmares for any retina specialist.
Sure.
So what are your take-home point
Dr. Rajesh
what
Kapoor.
could have been done in the first case, first go, so that the re-RD could not happen?
First,
Yeah.
like we thought that whole vitrectomy was done, but it was not. Some membranes were still remain. And second thing, that retina was sciatic. So at first place, ideally we should maybe we should take a chance for putting a buccal itself in first primary surgery.
Thank you.
Please
Since
play
Dr.
the video.
Ashutosh Kumar Gupta here,
Audio.
so he should come on the other side. And after that, Pranav Ranjan.
I am Dr. Rajesh Kapoor from Navi Mumbai. A routine phacoemulsification surgery was planned. Everything was going on well. All cortex material was removed. And in the end, I routinely cleaned the posterior capsule by flushing with 3 cc BSS saline. So that was done. And before loading the IOL, sudden posterior capsular rent was observed, probably due to forceful flushing. This has never happened before, but it is very effective way to clean the posterior capsule. But a lesson was learned. Be very gentle while flushing or cleaning the posterior capsule with BSS. Thank you.
I think now, particularly I feel the posterior capsule fibers which are, particularly if you are using the EDOF lenses or multifocal lenses, and if it is in the center, you need to flush them because you want the patients to have very good vision. But if they are in the periphery, I think it's best avoided. And if they don't come up very easily, I mean, you need to make sure that the pressure inside doesn't build up and the fluid is actually leaking when you are flushing. Otherwise, it will build up the pressure. Yeah. And of course, the another methods are of course available to polish the capsule.
And especially in myopic eyes and with thin PCs, it is more common, and yeah, it is very common and a good point. Thank you.
Thank you. Thank you.
See, we do not polish the capsule by any suction method most of the time because the tip is facing upwards. It is only after polishing you are sucking it. And once you're closer to the capsule, only idea is not to have so much of a vacuum which suddenly capsule comes into the port and you may tear it. So, but in any case, capsule never tears by suction alone. It only tears when you are stuck in the capsule opening and you suddenly remove your handpiece. If it gets stuck, once it got stuck while I was operating, it won't come out. I use the iris buzzer, pull it out, still the capsule was intact. Because in a periodic cataract, when you try to do capsule access, then you realize the capsule is not as fragile as we think. So they really withstand a lot of pressure.
Thank you, sir.
Dr. Ashutosh Kumar Gupta.
Dr. Pranav Ranjan. Dr. Salim Kaur.
Good morning, Sarah ma'am. In this next 1 minute, I am going to show you a very innovative technique of fixation of dropped AIOS type IOL with the help of just 90-proline. The advantage of such a technique is that, first, I have not made any corneal astigmatism, I have not made any corneal incision, just a small with side port, no scleral incision, intra-op IOP control is good, there is no post-op astigmatism, and in the last, it's the cost effective because I have used the same IOL. And one more advantage of this technique, I have used a partial scleral groove. So post-op there is no visual 90-proline or that knot. Thank you,
so
sir.
at what only problem with this type of technique is that when you are trying a suture and on both the sides, whether they are at the same place or not, may be difficult to decide.
Sir, it was a 4-point fixation and I have used 2 mm and 2 mm and it was well centralized.
No, I mean, you are
Sir.
trying to fix the haptic over there.
Yes, sir. Sir, I have fixed, there was no sulcus support because there was IOL back complex drop.
By
Yes.
suture, you are fixing the haptic to the sclera.
Yes, sir.
So this is what I'm saying, at what place of the haptic your suture is staying may not be determined very easily.
Yes, sir.
So it may be slightly more on the one side or the other side, maybe towards the tip or maybe where there is a optic haptic junction.
Sir.
So having the both sides equal and same place may be difficult.
It's definitely,
So
sir.
the
Sir.
only, this is slightly difficult technique, maybe all right for VR surgeons. And I personally feel that putting an exact centration may be a little
Sir,
difficult.
sir.
Because
Sir.
when you are passing a suture in such a complicated technique, and even the suture may slip on this way or that way.
Sir, but it's not a very complicated technique. But
the whole procedure is being done literally in the vitreous cavity. You're not even.
Yes, ma'am.
It's
Ma'am.
just in vitreous
But
cavity.
I've done. This is my.
We know that.
starting-
We have seen many of the videos. My only concern is that it may be having the perfect centration may be an issue in these cases.
Sir, in most of the cases, I have done, this is like AIOS type IOL, I have tried PMMA also, I have tried via passing the hole, I have tried all the lenses, the centration, and there is no, as such, no post-op astigmatism is not much.
I think excellent technique, and most of the VR surgeons have been doing it.
Sir.
And we have been seeing it, particularly one-eyed patients, highly myope patients, where you don't have to really open up the anterior segment to take it out. So it's a closed chamber technique.
Yes, sir,
Very
sir.
good technique. There is absolutely no doubt there with a lot of benefits.
Sir.
And once in a while, of course, if the biometry is not correct, patient may have a refractive error
Sir,
afterwards.
I have asked, like before fixing the same IOL, my first question is, were you happy with your previous, were you happy with the IOL when IOL was in place? They said, we are happy. Then I said, I will try to fix it. If it's not done, then I will put the another lens.
Okay. Anyway,
Thank you,
thank
sir.
you. So we'll go on to the next speaker.
Dr.
Is-
Savleen. Dr. Savleen, please.
Good morning, sir. This is Dr. Pranav Ranjan.
Sir.
Good morning, Dr. Harbans Lal, sir, chairperson of the audience. This is a situation which is not encountered very frequently. So the lens goes in upside down. So what to do in that situation? Should we leave it like that, or should we tumble it in the correct position? Because with the multifocal lenses, toric lenses, AIOS lenses, putting it in the correct position is the best way forward. So what has to be done? The upside down lens has to be brought into the anterior chamber, and then with the help of two instruments, two Sensky hooks, using the primary incision and the side port, taking advantage, mechanical advantage, we can always tumble the lens and then put the leading haptic in the bag, followed by the trailing haptic. The reason why it is not unsafe is the fact that the entire depth from the endothelium to the posterior capsule is approximately 7 millimeters, the lens being 6. So it is always safe if we do it in a proper way. So this is the right way. If you land into such a situation, one should always try this technique.
Thank you, Dr. Ranjan. And I think the another important point he already brought up about the EDOF lenses, because these lenses, the total power, some of them may have on the posterior surface, some of them may have anterior surface, some of them may have in the center. So different type of lenses, and according to the lens thickness, so that means your biometry may go wrong if it is upside down. And so it becomes very, very crucial if you are using the multifocal EDOF lenses. But nowadays I have started using, I'm now using what I call as a hydro maneuvers more inside the eye. I mean, whatever the viscoelastic can do, same thing can be done by maintaining the chamber by putting the irrigation cannula in. So I just put irrigation cannula, use it as a one instrument, and put another instrument from other side and tumble it. Because I put all toric IOLs, everything under hydro. But of course, Hilon GV or Viscoat will be more ideal for the beginners. There is absolutely no doubt about it. No doubt about it.
So viscoelastic more because due to the protective effect on the tissues like endothelium. That was one reason. Otherwise,
particularly the chamber is shallow, high power lenses. Myopics you can do very easily without any problem because the chamber is very deep. But if you are not experienced, yes, good viscoelastic helps and it is very, very easy.
Thank you. Thank you, sir.
Dr. Savleen, please.
Good morning, everyone. In contrast to the others, I'm going to show a diagnostic technique and a tip so you can carry home to remember.
Demonstrates
Can I
the
have
use
a
of
volume,
the
please?
anterior segment OCT for pediatric cataract surgeons. AIOS2025 can be used as a table mount machine or the integrated intraoperative OCT. An easy way to remember the indications is by the word OCT. O is for opaque. When the cornea is opaque in the setting of a dystrophy or scarred due to trauma, OCT helps in diagnosis. C for capsular abnormalities like plaques, fibrosis, and defects in the posterior capsule. When seen on OCT, makes us better prepared. T for total cataracts, where fluid pockets as well as integrity of the capsules can be made out. Note how the scan passes from nasal to temporal end, demarcating the area of dehiscence and herniation of contents in vitreous. Dry aspiration and low settings in these cases leads to a successful surgery. For a safe pediatric cataract surgery, remember OCT. Thank you.
So first of all, it's very difficult to acquire OCT in such a child, making him, I don't know how would you do it like pre-operatively? How do you do the AIOS-OCT for such small children?
Thank you for that question. I totally agree it's very difficult, but with the newer swept source machines, it's taking a scan in 3 seconds. So we are either straddling the baby in a butterfly position or making this baby upright. And we also have intraoperative. I know it's a cost involved, but if you have access, I think it's an add-on tool, complementary to your examination.
So does it help in planning the posterior capsular rhexis or anything? Does it help in the surgery, like any step of the surgery which it can make easier for the surgeon?
It is very useful for the posterior capsular rhexis.
Apart from diagnosis,
Yes, apart from diagnosis, it's the only technology that can actually look at the vitro-lentil interface.
Yeah.
So vitro-lentil interface in a child, especially the Berger space, you can anticipate a difficult capsular rhexis, the posterior capsular rhexis. It's not that tough for experienced surgeons, and we have been doing it without the OCT for years. But if a novice surgeon is doing it and you have the OCT, you can actually see the attachments of the Berger space, and you can anticipate whether you can do a rhexis or better put an IOL and then do a rhexis. So I think that is a change in step that I do before.
Thank you.
Thank you.
Dr. John Davis.
Glaucoma surgeries, MIGS in 3D printed and mixed reality by Dr. John Davis Akara. The authors have no financial interest in this presentation. All the designs are open source and uploaded for free on thingiverse.com and 3d.nih.gov. We have designed 3D models of the iStent Inject and iStent W Inject using free software such as FreeCAD. These models can be 3D printed and also rotated in mixed reality. We also modeled the Kahoot Dual Blade Glide, KDB Glide. All these things can be printed easily in a resin 3D printer using the SLA LCD technology. We also designed some other models of glaucoma drainage devices, and these can also be 3D printed. We have also made 3D models of Seoni CTR, regular CTR, CTS, and VHEX-NIC. We have also uploaded these designs to the National Institute of Health NIH 3D website. After you download, what do? You can go to Google Maps and find a 3D printing shop near you. So thank you. I hope this will help you to 3D print your design.
So how much IOP control are you aiming to achieve with your stents?
These are not for human use. These are for wet lab practice and teaching purposes. So that's just a model of what you can do with it. You can use 3D printing to design new things, to make prototypes, and for teaching and for wet lab practice. And you can use it in augmented reality also.
So I think this topic is needs a little more explanation, and this was not fit for this.
For this 1 minute class.
It needs a lot of discussion and to understand.
Okay,
Anyway,
the point is you can use 3D printing to make prototypes of innovations that you have.
yeah, I know that.
Basically, the whole technology, not the.
So many of them even won't know what 3D printing is, how much cost is involved, what all can be printed, and what all is required. So it's really, I visited LV Prasada Institute to see their 3D printer when I was the president, and we had a tie-up with the LV Prasada Institute and All India Institute, All India Optometrical Society. To all those who want to have the innovation can get tied up with the LV Prasada Institute, and they can have a 3D printer. But it's a wonderful machine costing more than 10 CR. And you give any design, they will do the 3D printing, and whether it's a metal, plastic, they will manufacture for you.
I would like to add, so if you want to get started with 3D printing, you can buy one for 15,000 rupees. Amazon, Google 3D printer, you can get 15,000 rupees.
But will it be able to manufacture?
You can make prototypes. You cannot use it in the human eye, but you can use it in the wet lab. You can show it to patients. You can use it to teach your students. You can use it in classrooms. You can use it for
what all material it can handle? I mean, plastic
So
only?
the 15,000 rupees one can handle plastic, PLA, ABS, and those sort of plastic which are flexible also. There is another one for around 30,000 which can handle resin, which gives a high resolution resin, which you can make transparent, translucent materials. If you go for a metal 3D printer, it goes to 10 CR.
How much that? How much that?
Metal is 10 CR. You don't need metal.
So
you
they
just
provide
can use
the
this.
plastic along with that?
So I would go for the plastic one for our own purposes, and once you want a final prototype, then you go to the companies and outsource that part alone.
They give the material along with that 3D printer?
So the material for the plastic material is 800 rupees per kilogram, and you use few grams for every prototype.
Okay,
So
thank you for bringing out a wonderful point. So all those innovators who really want to do something, there's something is stuck in their mind. So the 15,000 is nothing you can buy and try at home.
Yeah.
Thank you very much. Excellent presentation. So now we go to the next
Dr.
speaker.
Sugato Paul.
Yeah. Good morning. So I'll be presenting hydroimplantation of IOL with a screw injector. So if you are hydroimplanting an IOL with push injector, we all have this nightmare where IOL is shooting out and rupturing the PC. So what I'm doing, I am doing hydroimplantation with screw injector, where I am using my assistant third hand to do the screwing. So you can see how controlled the IOL insertion is. When the IA is done, I keep the irrigation in, the IOL is loaded, and I put the cartridge in the wound, and my assistant, he control and screw the IOL in under hydroimplantation. In this way, I am getting best of the both world. So there is no leftover visco in the AC because it's hydroimplantation, less dust, less IOP, and screw injector, no IOL shooting out, and no rupture of the PC. Thank you.
Thank you. I'll tell you, I have been doing all my implant surgery under hydroimplantation. When J&J came with their high advanced lenses, they had a screw injector. So it is very difficult to do the screw injector with the hydroimplantation, particularly if you are using the toric IOL. You have to use the Hilon or a hydroimplantation. If you put on a viscoelastic, then you cannot remove the viscoelastic completely from the back. So now what I'm doing, I take a regular cartridge and inject the screw injectors IOL into the regular cartridge, then use the regular cartridge with the original injector and do the hydroimplantation.
Yeah.
Very easy. So take the screw injector, just put on instead of injecting in the eye, take the regular cartridge, inject into this and throw it. And then put on a regular cartridge onto your routine steel or titanium injector and then do the hydroimplantation. Because the screw injectors have got another problem. You need 2.75 millimeter of incision size. They don't go through 2.2 or 2. So the regular injectors wound assisted, you can go through 2.2.
No, sir, I have a point to make. So my whole idea of presentation is hydroimplantation with push injector you are doing with the new lens as well. But chance of IOL shooting out, as you have seen in my video, and damaging the posterior capsule is there. With screw injector, it's much controlled delivery. But as you have said rightly, with screw injector, you have to use it visco. So what I am doing, instead of visco...
I got your point. What I'm saying, there's an alternative method. I'm not saying that you cannot do with the assistant. And so you need to have good assistant. What I'm saying that for two reasons. One is that I'm not saying you should not do it. I mean, in your comfort. But the incision size, usually J&J, at least I don't know.
J&J, they have take 30, which is 2.2 millimeter. And Alcon has D cartridge, which is 2.2 millimeter.
J&J never goes, screw injectors never goes from 2.2 millimeter. It
I said last 15 years
goes, sir. Sorry.
Take 30.
So their pre-injected one, they go easily 2.2. Yes, they do. The newer ones.
So I have not been able to inject from 2.2 because whenever you want to do the wound-assisted implantation, you need a better control and a counter pressure. So I don't think the J&J injector goes inside the eye with the 2.2.
Thank you.
Even their routine injector actually goes with a lot of difficulty with the 2.2. You need 2.4. It could be pure wound-assisted because you should never force anything inside because the clean cut is better than a tear over there. So if you are pushing an injector which through 2.2 and it needs 2.4, actually you are doing more damage than psychologically having a benefit of that I made incision 2.2.
Yeah.
So if it goes inside comfortably, it's fine.
So
otherwise, it's better to have, there will be no harm done if the incision is 0.2 millimeter larger or 0.3 millimeter larger than if you are trying to push it.
Yeah, with this method, actually, you have to increase with 2.2 to 2.4, as you have said, because I'm putting the nozzle of the cartridge inside the anterior chamber.
Even the J&J machine 2.2 is little tight. So I have been using 2.2 for ages, for last 20 years or so. Recently, for last 1 year, I've shifted to 2.4. I find that 2.4 is much more smooth entry for J&J products than 2.2. And you try it, you will find that how easy it becomes. So even the sleeve and all, because you don't use the fresh sleeve all the times. So these sleeves are also a little softer over a period of time. You keep on autoclaiming. So when you are trying to put it through 2.2, it goes with little difficulty. But 2.4, it goes in smoothly.
So now I feel it easier to put it the regular way with the viscoelastic and then later on go under the IOL and remove the viscoelastic.
So there'll be many situations where you don't like a small pupil. And secondly, this unnecessary step, you save the time, you less inflammation, less IOP rise, you don't have to go underneath, less cost effective. So all those things, hydroimplantation is a wonderful technique. Everybody should try to master it if it is possible. But of course, everybody has got its own reservation. Viscoelastic we have been using for centuries without any side effect, and you can use it. There is absolutely nothing wrong.
Thank you.
Thank you.
So just one more thing, instead of giving the assistant to, unscrew the injector, can't you just give him the cannula and hold the irrigation instead of...
As you have noticed, see, if I give the cannula to him, he can go in and rupture the PC. So cannula is helping me not only for irrigation, but also manipulating the haptic of the IOL, if you could have seen in that. So that's why I'm
also because you need a counter pressure.
Yeah.
Otherwise,
because I'm holding both the things,
from
I
this
know
side, the cannula has to push to the other side. That's perfectly all right. You can't hold
and for screwing the assistant, they don't need any training. I work in different hospitals, and everywhere I'm doing the same technique, and other doctors have also taken that technique.
We are running out of time now.
Thank you.
Now we have got the last speaker, Shristi, tackling subretinal silicone eye.
Good morning, respected teachers and my dear colleagues. I'll be presenting a case of tackling subretinal silicone oil in a PVR patients. Video please, with full volume.
Subretinal silicone oil migration is a challenging case to tackle. This was a case of retinal detachment under silicone oil. After meticulous removal of PVR, a localized retinectomy was made superiorly, where subretinal silicone oil was noted. Using a blunt tip attached to a viscous fluid control, removal of subretinal silicone oil was done under visualization. After silicone oil was removed, subretinal band, and extensive PVR changes were removed. Retina was then settled with the help of PFCL. And its margins were lasered.
Thank you.
Thank you
Thank
to
you.
all of you. And with this, we come to the end of this session. And if there is any presenter who has not presented but is still in the hall, he can request us, we can think over it.
Dr.
Otherwise, done.
K. Sai Rani and Dr. Anurag Kumar Kashyap, two of them have not been there, not present. Thank you.